Good morning. I'm honored today to introduce our Grand Round speakers, Dr. Sandeep Narang. Dr. Narang received his Bachelor of Arts from Auburn University, his law degree from Vanderbilt University, and his medical degree from Georgetown University. He did his pediatric residency at the National Naval Medical Center and his child abuse pediatric fellowship at the Kemp Center for Child Abuse Prevention and Treatment at Children's Hospital in Colorado. He was a trial attorney for the United States Navy Judge Advocate General's Corps from 93 to 97, and has served as a general medical officer on the USS Sacramento during Operation Iraqi Freedom, and is a decorated veteran of the US military. He has held multiple academic positions and is currently a professor of pediatrics at the Child Advocacy Center at Children's Wisconsin. He is recognized as a national and international expert on child abuse and neglect, with an emphasis on abusive head trauma and the medical legal aspects of child maltreatment. He's the lead author for the recent American Academy of Pediatrics policy statement on abusive head trauma and expert testimony in civil and criminal proceedings. And he has previously received the Fulbright Nehru Scholarship for Child Maltreatment Research in various parts of India. He is certainly the only person that has this type of expertise, being both a child abuse pediatrician and an attorney. And I think you're going to be very excited to hear what he's going to speak about. He's going to be going from here to give the keynote address at our 18th annual Conference on Child Maltreatment down at the Convention Center. So we have almost 450 people down there waiting to hear him give a similar talk. So I think you're really going to enjoy this. Thank you.
Morning. So it was a real thrill for me to see one of my old military colleagues, Dr. Dobson, this morning. I was not expecting that. That is just a joy. I want to thank Dr. Clayton, Dr. Berger, Dr. Spears, and this great institution for this honor. I don't want anybody to freak out, okay? You're not going to be in a counseling session despite what my slide kind of shows, okay? Although after what you hear, you may feel like you need a little therapy. But in true attorney fashion, I'm going to start with disclosure, okay? This talk is not your typical medical talk. If you came to this talk expecting an exposition on the basic science of various findings in abusive head trauma, and or possibly even for me to talk a little eloquently about the advancements of neurobiomarkers for abusive head trauma and clinical diagnosis, I'm sorry to disappoint you. This ain't that talk. Okay, this talk is going to, mind you, I'm going to give you a little bit of the scientific advancements because it forms a premise of the way we want to approach the systemic problems this concept creates. But given this august body of deep thinkers, I wanted to start with talking about the much larger problem of translational information, of medical information into the court system, and the differences of interprofessional communication, of frameworks, and how it's caused a certain degree of controversy and mayhem in systems that you and I probably don't recognize. So let's get going. So this is my disclosure slide. Here's a roadmap of what I hope to cover with you. First and foremost, I want to start with a little bit of a brief history of abusive head trauma. I think it's important to set the predicate for where we are today, and then obviously for where we're going to go in the future. And I'm going to then very briefly go into the current day science and evidence base for various clinical features of abusive head trauma and the rigorous science that's gone into validating those features. And then I'm going to take you into the underbelly of this diagnosis, okay? I'm going to expose you to the legal controversy surrounding this diagnosis and what we as pediatricians can do to impact it in a more positive course in the future. So this is my teaser slide. Anybody know about the Choluteca Bridge in Honduras? For those who are my virtual, if you're raising your hand virtually, great. I'm going to hopefully tie this metaphor in at the end of the talk. For the purpose of this talk, you and I are Martians, okay? And on the world of Mars, we live in this concept, clinical world, where abusive head trauma exists. But many of you may not be aware that the earliest pennings of child maltreatment, and especially of abusive head trauma, course back centuries. First of all, to this gentleman here, a French forensic physician named Auguste Ambroise Tardieu, who initially documented the pathologic findings of maltreatment in his book, The Forensic Study on the Ill Treatment of Children. And although Tardieu had held prominent positions in French medicine, his advocacy for children and the ill treatments that they suffered went largely unheard in his time. And partly that was due to the prevalent medical theory that pervaded science at that time. And that was the theory put forth by this gentleman, Louis Pasteur. Because of the works of germ theory, a lot of the conditions we now recognize that have other etiologies, such as scurvy related to vitamin C deficiency, or even rickets related to nutritional deficiency and other potential causes, those at that time were thought to be infectious. And that included traumatic etiologies such as subdural hemorrhages. They were thought to be infectious. And that was partly because Louis Pasteur's thought really pervaded a lot of different disciplines of medicine, even the surgical specialties. And so this prominent surgeon, Virchow, who noticed membranes when he cut into human skulls, noticed a membrane and thought, hey, this has got to be something related to infection. And he termed subdural hemorrhages with the term pachymeningitis hemorrhagica, giving it that connotation to infection. Then enter stage left this gentleman, Sir Wilfrid Batten Trotter, who's a British neurosurgeon in the early 1900s. He was a vanguard in thought and held eminent positions in medicine, not the least of which was he was the personal physician to King George V. But Trotter was extremely disturbed and frustrated by the concept of pachymeningitis hemorrhagica, and in 1914 published the report that trauma, not infection, was actually the true cause of subdural hemorrhages. And because of Trotter's stature in medicine at that time, it kind of gave other prominent neurosurgeons the latitude to explore and validate this kind of concept. And so Trotter's work led other prominent neurosurgeons such as Harvey Cushing to re-examine their beliefs regarding subdurals, and they began to validate the true traumatic nature of subdurals being trauma. Then enter this gentleman. This is the Dr. John Caffey, widely recognized as the father of pediatric radiology. In the 1940s, Dr. Caffey began to associate osseous findings with findings within the head. And he reported on a case of 6 infants that had subdural hemorrhages and long bone fractures, although they had no medical etiology to explain them whatsoever. And Dr. Caffey did not go as far as to implicate caregivers in relation to that, because he was just unwilling to do that at that time. But he did actually, in personal correspondence to his medical colleagues, express his deep concern that this was inflicted injury, although he would never publish it as so. Finally, I think if I were to summarize history, then came this gentleman, this brilliant pediatrician, Dr. C. Henry Kemp, who in 1962, along with his colleagues, authored this landmark article, The Battered Child Syndrome. And Dr. Kemp et al. Identified a constellation of inflicted injuries, which included subdurals, retinal hemorrhages, bruises, and broken bones without explanation other than inflicted injury. But unlike his predecessors, Kemp expressly noted that these were inflicted injuries by caregivers. And we could no longer, as medical providers, stand by, that we had an ethical obligation to the child to do something about it. Kemp's work was transformational in terms of medical, but I don't think you realized the transformation it would have in other systems as well, specifically in the legal system, because at that time there weren't established legislation in the 1960s regarding child maltreatment. And so Kemp's work started out the enactment of both federal and multi-state legislation for physician reporting of child maltreatment, and soon thereafter, obviously criminal statutes ensued. And suffice it to say, although Kemp's work and his colleagues had honorable and ethical intentions, they probably to some degree unintentionally transformed the entire medical legal landscape. More specific to the abusive head trauma diagnosis, the progenitors of this diagnosis came approximately a decade later. In 1971 and in 1972, two other physicians. The gentleman on the left is a British neurosurgeon named Dr. Norman Guthkelch. The gentleman on the right is the previously aforementioned Dr. John Caffey. On two separate continents, in roughly a year's time, they published two different reports outlining infantile injuries, subdural hemorrhages, to be the result of whiplash mechanisms. They based these hypotheses not only on previous biomechanical engineering work of a gentleman by the name of Amaya, who had demonstrated the production of subdural hemorrhages in whiplash incidents to primates, but also upon the admissions of parents in their case reports. And they use that as kind of the stepping stone for the hypothesis of this diagnosis. So that brings us to, so to speak, current, almost modern day. If you're willing to allow me that bell-bottom pants and flock of seagulls is relatively modern, that we struggled at this time in the 70s and 80s to actually even identify a term for this diagnosis. We had so many terms floating about: whiplash shaken infant syndrome, inflicted childhood neurotrauma, shaken impact syndrome. And then finally in the late 80s and 90s, not truly understandably why, a term called shaken baby syndrome took hold in both medical and common societal vernacular. And it kind of stuck from that point until 2009, when the AAP, for a variety of valid reasons, did something that I'm going to say is inconceivable. And they termed this they changed the term from shaken baby syndrome to abusive head trauma. And of course, there were valid reasons for doing so. But this bouncing around in terminology actually had a lot of problematic consequences in the legal community, because in the legal forums, any sort of change or confusion or doubt is not something that's preferable. But as a lack of consistent terminology has infected this diagnosis, so is the lack of clear diagnostic definition. While shaken baby syndrome had a clear diagnostic definition with regards to violent shaking, the use of the term syndrome was a little bit confusing when parents admitted to other mechanisms rather than pure shaking. And for example, just pure slamming against a soft surface. And so that didn't quite fit with the syndrome. And thus, in about 2000 and early 2010s, the CDC recommended this definition, which sort of galvanized public health research into a sort of a common definition for research purposes. But I believe the simplicity of the framework is really nice for clinical application as well. Now, as this slide depicts, in the last couple of decades, the advancements in abusive head trauma research have been vast. To name a few, they've included large epidemiologic studies, biomechanical studies on shortfalls in a variety of different aspects of infant head injury. They've included research in a variety of different subspecialties listed here for you, from neurosurgery to ophthalmology to emergency medicine, critical care, of which this institution is a great contributor, and ophthalmology and even pathology. It would be impossible, and I would even say irresponsible, for me to try and galvanize all of that meaningful research to you in just a short 25, 30-minute period, okay? But what I am going to try and give you is the Cliff Notes, and it's probably sad for me to say that some people in this audience have no idea what a Cliff Note is, but it has salvaged many a college careers, including yours truly. And I'm going to give you the Cliff Notes of this voluminous research of 2 decades in about 10 minutes, okay? So let's start with where we all start in our clinical encounters, and that's the history. The historical adage has been that an absent trauma history in trauma findings, or a delay in seeking care, and others are long-term red flags for suspicion of abusive head trauma. But those have been premises that have been largely experiential in base, until, first of all, this article was published in the early 2000s. This article, this study that emerged from a brilliant peds emergency group in Children's Boston, Hetler and Greens conducted a retrospective review of 163 children aged 0 to 3 that were admitted for head trauma. at their institution to test the very hypothesis of whether discrepant history, initial history, could actually validate predictive findings. Their cohorts were classified on stringent criteria, radiologic, osseous, and ophthalmologic, which were completely unrelated to the history. And what they found was that when there was the presence of traumatic findings, and there was no trauma history that was provided by a caregiver, it held an inordinately high specificity and positive predictive value for abusive head trauma. Now, given the fact that this was a retrospective review, had some limitations to it, it was really, really a nicely well done study, but still probably not dispositive. But then, of course, then came this study in the late 2010s by Email et al. And they published their work, which essentially sought to replicate the objective that Hetler and Greens had set out in 2003, but to utilize this on a prospective data set that was collected across a multi-site traumatic brain injury research network known as PediBurn. Email et al. Examined the data on 346 acutely head injured children who were hospitalized in intensive care units between 2010 and 2013, and a priori categorized, again, their groups similarly to Hetler and Greens, based upon either clinical findings that were unrelated to the history. So they either had to have radiologic findings that were clearly demonstrative of abuse. They had to have either skin findings like loop cord injuries, clearly things that were clearly dispositive of abuse. And then, of course, they went back and said, what do the histories show us? And Email et al. Found in their prospective data set, similar to what Hetler and Greens found, that a caregiver's specific denial of abuse, of trauma, had extraordinarily high specificity and positive predictive value for abusive head trauma. And so we had two well-conducted studies, one from a retrospective analysis, one from prospective cross-sectional data set, which gave us the same historical premise that our experience had taught us. Now, you and I can most certainly recognize that there can be a variety of different reasons that a caregiver may come into us and provide us either a concealed accident, they may feel ashamed, they may feel embarrassed, or they may even not know about what's going on. And that's most certainly what we consider when we gather the history, absolutely. But the premise of this evidence base is that for you and I to wish for that without doing a thorough evaluation for non-accidental trauma lies contrary not only to the evidence base, but to the best interest of the child. So let's turn to the domain of our physical exams. You and I all know that bruising, especially in young infants that are learning to toddle, is ubiquitous. And the discrimination of abusive bruising from accidental bruising can be extremely clinically challenging. Pierce et al., a previous colleague of yours at this institution, sought to derive a clinical differential rule that would differentiate accidental from abusive bruising by body location. In this study, her initial study, a case control study from children 0 to 48 months of age, who presented to the PICU because of trauma, Pierce et al. Examined 71 patients who had bruising on exam. And again, based upon a priori criteria, she stringently classified cohorts that were not related to the bruising findings. So she ended up with 33 that were in this stringently accidental cohort and 38 that were in the clear abuse cohort, unrelated to the bruising. But the problem is that a picture, and that was a lot that existed in medical records or even in our assisting evaluations at that time, is worth 1,000 words, but it really frustrated researchers like Pierce et al. who couldn't translate those pictures into data. So what, undeterred by this challenge, Pierce et al. Then enlisted the assistance of a software company and created an extremely detailed anatomic software to help record and analyze this data. And this was called the humogram. And you can see a small example of sort of how it works there. But what it did was it really began to show us the power of visual data and how certain regions began to differentiate in abuse and accidental cohorts. And so Pierce et al. Initially published this derivation study, the 10-4 clinical decision rule in 2010, but it led to a much broader study that the NIH funded in multi-sites across the United States, where they ultimately were able to examine the validity of this decision rule in a larger set of patients, well over 2,000. And what Pierce et al. Published in 2022 was the validation of this clinical decision rule. And what they found was that they were able to more refine this 10-4 rule into what has now probably been more ubiquitously used in emergency departments all around the country, and probably even here, is the 10-4 phases rule. And essentially it says that if you have bruising in the torso, ears, and neck, or the soft part, especially the soft part of the torso, in any child less than 4 years old, or any child less than 4.99 months, and any bruising to the frena, the soft cheek, the angle of the jaw, the eyelid, or the subconjunctiva, you had really high sensitivity and specificity for identifying abusive bruising rather than accidental bruising. So that really assisted our refinement of our physical exams. But aside from these large multi-center studies, large systemic reviews, additional data came from across the pond in one of the most stringent study designs you and I could ever conceive of. And that was looking at only confessed abuse cohorts in open court versus witnessed accidents. And what that did, so Vincent et al., which is a neurosurgery trauma group out of France, they prospectively maintain a trauma registry there that has comprehensive data, and they've been keeping it since 2001. That detailed clinical information includes not only the neuroimaging, a vast detail of historical information, at least one ophthalmologic exam in all of their patients. They selected out 45 confessed cases in open French court. So these are not confessions induced by French police. These are open source information of French judiciary. They selected out those 45 cases and compared them to 39 accidents that were witnessed by at least one independent adult in a public space. And what they found was that a discriminatory feature emanated. That discriminatory feature was a pattern known as severe retinal hemorrhages. And that severe retinal hemorrhages is a pattern that's usually multi-layered and extends way out to the periphery of the eye, known as the ora serrata. And it is very different than any other pattern that we see in trauma. And it had extremely high specificity and positive predictive value for abusive head trauma. But that's not the end of the retinal hemorrhage journey in terms of science. Of course, we as scientists know that while trauma can offer a certain pattern, the real specificity of it comes from its exclusion in other subsets. And that's what we've done over the past couple of decades. Retinal hemorrhages have been explored in virtually any and every pathophysiologic entity you can think of. CPR, I've listed for you 2 separate prospective studies. Severe vomiting and retching, 2 separate studies. Seizures, birth, severe cough, where intrathoracic pressure could be a postulated mechanism. Increased intracranial pressure. Every single one that you can possibly conceive of in the past 2 decades has been studied, and severe retinal hemorrhages are non-existent in those pathophysiologies. So let's go to advancements in shortfall research. Now, of course, that has to be a topic of study because the most common history we are provided when a child comes in with really severe brain injury is the fall off of a very innocuous surface, right? The short fall off the couch, the short fall off of a bed. And we, of course, being scientists, have wanted to study this in every conceivable aspect. And over the past couple of decades, we really have. I've listed just some of them for you. We've surveyed caregivers anonymously in 2 different continents. We've examined findings in verifiable settings, daycares, hospitals. We've examined falls from various different heights. We've examined falls from a variety of different biomechanisms, whether they've fallen down stairs, whether they've fallen down stories. We've examined studies that have included biomechanical inclusion into clinical work and gone out to scenes and reconstructed the biomechanics of it. We as scientists have studied this from virtually every single aspect that you can possibly imagine. And we've even done large epidemiologic studies on it. But one of the important things that has happened is we've always known clinically that shortfalls are, nothing is 100%, right? Shortfalls is an extremely rare phenomenon to result in mortality. We've known that for a long time. But this really nice study by Chadwick et al. In the late 2000s gave us finally some epidemiologic granularity to that proposition. And what they did was they surveyed the published medical literature on shortfalls in virtually everything. Book chapters, medical society statements, major literature reviews, large public injury databases, 177 peer-reviewed published articles in the National Library of Medicine. And they looked at virtually every single piece of data that could be existent. And they finally gave us some epidemiologic data on what is that risk. And it's estimated to be roughly 0.48 per million. That's an estimate. So not something that I would tell a court it's definitively, that's exactly what it is, but it gives you some degree of granularity to how rare this phenomenon is. I would submit to you their estimate actually is probably even an underestimate because their epidemiologic database didn't count each and every single time a fall happened. It was based upon population-based work. Now, further advancements include where we currently kind of go. So we've recognized, we've derived all these independent variables, some of them which I've given you. So whether it's apnea, whether it's seizures, whether it's historical findings like 10-4 bruises, or whether it's long bone fractures, retinal hemorrhages, we've individually derived all these variables, but what do they mean in collective clinical cases? How does that give us, how does it give us some sort of predictive capacity when we're pooling all these variables like you and I typically do in a case scenario? This was one of the work that helped us kind of meaningfully assess sort of these multiply derived variables into a probability for abusive head trauma. This work by McGuire et al. Essentially gave us, when you had all these independently derived variables, essentially it said the more variables you get that are independently derived towards an abuse diagnosis, the higher your odds are that this is going to be an abuse circumstance. And this is another one right of that Pediatric group. And it essentially states that the more validly derived independent variables you are, so it goes from 3, 4, 5, 6 to 7 variables, the higher your probability for abuse is. And it gave us all the different ways and the different sort of mathematical sort of computations that you can get for getting this abuse diagnosis. So my summary for you is that as scientists, we've done a fair bit of research on this. We found historical features and we validated them that are strongly associated with abusive head trauma. We found clinical symptoms in the trauma setting. We found clinical findings in the trauma setting. And we're starting to evolve these into statistical strength of collective variables. And there's a high degree of acceptance for us that this diagnosis is real and that certain findings should really point us towards this diagnosis. But I want to turn you to the other planet. Meanwhile, in the legal community, there is a great degree of controversy about this diagnosis. Why so? I think some of it starts from the historical premise that as much as you and I really think highly of ourselves, we as Martians haven't really been well viewed historically, even in the legal community. As this one litigator wrote in this long exposition about frustrations about expert testimony, he said, "Gentlemen of the jury, there are 3 kinds of liars: the common liar, the damned liar, and the scientific expert." So this frustration stems from a long and storied history, just like that long history that I gave you for abusive head trauma. In this parallel universe, there's been this long history of experts coursing through courts. And what this exposition showed by this jurist here, one of the really, really well-written expositions on expert testimony by Judge Learned Hand, he wrote for the longest time that the problem with the expert is this, is that the problem with the expert is that the jury can't really truly discern between information that's foreign to their own. But it's that reason that the expert is necessary at all, and it poses a complete conundrum. So how do we resolve this? Well, in the legal community, They've tried to help it by saying, hey, whatever the larger medical community says, whatever is generally accepted, that's the Fry standard, and that exists in about half the United States. Whatever is generally accepted in the medical community is what is going to be reliable in court. And then there's another half that says, hey, we got to be a little bit more stringent than that. It's not just what the medical community says, but we want to know how they think. What is the methodology that the expert's going to use for coming to their conclusions, and how well do they enunciate when they get into court? That's known as the Daubert standard. What I would specifically say to you is that for the longest time on Venus, abusive head trauma and shaken baby syndrome were relatively unchallenged, 70s and 80s, until approximately this time frame when this case came out in the late 1990s. Some of you may remember this. Some of you probably have no knowledge of this whatsoever and probably don't even know what People magazine is. But in the late 1990s, the Boston nanny case came, and its ripples were really, really tremendous. And it's because the players are notable in this case. So what's depicted for you in the upper right corner are two attorneys. One of them you may recognize, one of them you may not. One of them is a prominent trial attorney named Barry Scheck. He gained his notoriety for challenging forensic evidence and medicine in the OJ case in the mid-1990s, specifically blood spatter evidence. And he was the trial attorney for Louise Woodward in this case. And he was extremely confident that he would be able to dismantle the scientific information in Woodward's trial, and specifically the shaken baby evidence that was coming forth in that trial. But he was unsuccessful. And this led to a great degree of frustration for Mr. Scheck. He began a very notable and worthwhile organization known as the Innocence Project, along with his colleague, Peter Neufeld. And along with trying to use DNA evidence, objective forensic evidence to convict individuals, they also had the secondary alternative of trying to invalidate shaken baby syndrome and abusive head trauma because they really felt like it was forensically unreliable. And that has been a secondary objective for the Innocence Project. They found a willing partner in this law professor here, Professor Turkheimer, who published this prominent law review article in 2009, where she raised some flagrant assertions that the SBS abusive head trauma diagnosis is essentially medically diagnosed murder, that doctors are the culprits, and that they premise this based upon flawed science, and that there is actually a shifted consensus in the medical community about the reliability of this science and the validity of this diagnosis. And that's because the science is gapped, it's flawed, it's circular, you name it. That's what they raised. Now, I want you to know that this is not just the disgruntlement of one specific trial attorney and a few law professors, but this is actually a systematic plan that is in place. Now, I would not be a self-respecting lawyer if I didn't have at least one Venn diagram in my talk, okay? So here it is. So a few of you may realize that the playbook that the Innocence Project has used is you make it easy for lawyers. So you give them the playbook of what to use. You give them these writings of this is where it's circular, this study is circular, this data gap is flawed, and you widely disseminate this information at defense conferences. But since you are working from a position of sort of being on the fringe or the minority position, you have to somehow gain credence to your proposition. How do you do that? Well, you use media to validate that message. And that's essentially what has happened over the past really decade and a half. They've used credible media sources, such as this one, to say, hey, is the science behind this topic really true? This is another one, NBC News. They sprinkle in a TED Talk here and there by somebody who's a neuropathologist, but a known defense expert. And you even put forth real docuseries on it. And you start to gain a degree of credence to that message. And then you employ it at a stage in the legal system where it's favorable for you to employ it. It's interesting that they don't employ this at the trial stage, because typically the trial court experts usually far outweigh the defense experts. The prosecutor has the burden of proof, so they bring in the child abuse expert, the ophthalmologist, possibly the radiologist as well. And there may be one defense expert on the other side if they have the funds to generate that. And so that stage is really not beneficial to them, because even if they were to generate 3 or 4 experts to contravene that, they probably still wouldn't have a successful outcome. But go to the appellate stage, where legal technicalities can potentially help you, where there's a lower burden of proof. And then not only that, you can parade in 10 or 11 expert witnesses, the same expert witnesses. The prosecutor or the appellate side has less burden to meet, and so they don't parade in witnesses. And you have a disparity in even witnesses at that level. And you've created a recipe for gaining some degree of success. Now, you may think, hey, that's an interesting proposition, Narang, but that's probably not true. Well, let me show you. Let me show you some of the consequences that it's had. One judge said that actually, based upon this kind of recipe, that shaken baby diagnosis is actually an article of faith more than a proposition of science. Another judge said that this is junk science. It shouldn't even belong. It doesn't even belong in a courtroom. Now, if you think it's just me cherry picking a few cases, here it is in an investigative piece by the Washington Post in about 2013. They found that approximately 213 cases in the prior decade of abusive head trauma were either dismissed or found not guilty, or convictions were overturned when there were clear, overt findings of abusive head trauma. So it's not just a couple of cases here and there. This is actually a much more prevalent problem. So I sought to study this and say, how prevalent is this problem? We looked at the appellate decisions for an approximately 10-year period. And what we found in the US appellate system, that at least 35 states had at least one overturned abusive head trauma case in the prior 10 years. But more concerningly, just in the fact that it was really prevalent across the United States, is that the rate of this is happening at an extremely high number, where it was 1 per roughly year in 2008, 2009. It's now 4-fold in 2016 and 2017. So this recipe is actually gaining traction, at least in Venus. Now, if you think that's kooky, it gets even kookier, okay? Of all those cases that we looked at that were overturned based upon flawed science, based upon the diagnosis not being true, that were sent back to the lower court for retrial, 40% of them subsequently either repled guilty or were found guilty again. It gets even kookier. So let me scare you a little bit. You may think that being one of the smartest 9 legal jurists in the land should insulate you from the proposition of junk science, but it does not. I'm putting forth on you this page a simple per curiam decision by the Supreme Court in 2011 by the late, great Justice Ginsburg, who was a brilliant legal mind. But she wrote this about shaken baby syndrome and abusive head trauma in a case. And this probably wasn't really detailedly written by Justice Ginsburg. Probably one of her law clerks wrote this, but it has her name on it. And what she wrote was that in the years following this trial, doubt had increased in the medical community over whether infants could actually fatally shake an infant. That there was an inadequate scientific evidence to come to the conclusion on causation, diagnosis, or treatment, or any matters pertaining to shaken baby syndrome. I know what you're thinking. What the heck is going on here? Why is this happening? Why is there such a disconnect between Martians and Venetians? I put this slide in jest. Okay, I know we want to blame lawyers for everything, but this is a much broader issue than this. This is a systems issue, okay? This is a systems issue and a systems that's being exploited by a few small players. So what are the systems issues at play? Let's start with this. Our two systems have completely different values. Medicine has the value that doubt is great, that through doubt, we achieve scientific truth. You test propositions, you continually challenge things, and through that, you will ultimately come at scientific truth. And you and I are comfortable. We are comfortable at the bedside living in worlds of probabilities. We know the human body works in that way. That's not the value system that exists on Venus. At least for prosecutors, doubt is bad, 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 bad. You don't want doubt. And can you imagine 10, 12 medical jurors on a jury? I mean, that's essentially the diagnosis you would get right there, or the conviction you would get. There's no guilty or not guilty. We would probably say, it's probably guilty-ish. It's probably likely guilty, maybe probably guilty. But that's not existent in law. Well, we also have different frameworks. There's a great false equity. Our system, legal system, has this peculiar phenomenon where we have to treat all experts the same. So the expert that walks in, and I've seen this, with a set of cow eyeballs in a jar and lays them on the witness stand, is the same expert who's given the same degree of credence as the preeminent pediatric ophthalmologist from the Wills Eye Institute. That has to happen in court. And of course, there's language issues, right? So you and I speak a language, lawyers speak a completely different language. When you and I say words like traumatic brain injury, subdurals, retinal hemorrhages, besides having cognitive seizures, what do lawyers do? Lawyers go, where does this fit in actus reus? Where does this fit in mens res? How do I meet my elements of the crime with this? I can't quite understand this. And you and I get that. We are trained in particular professional language, and we try and contextualize that language into a language that's native to us. But sometimes that doesn't quite connote the best understanding, right? It gets even worse. What about when we use terms that overlap? You and I say abusive, but it has an entirely different legal meaning for them. You and I use words like intentional, and I'm showing you the word intentional on the CDC page for child abuse, but it has an entirely different legal meaning in the legal world because it is a specific state of mind that has to be shown through certain things. But you and I are using that terminology in medical records all the time. And so these overlapping terms are causing a great deal of confusion. Not only that, even when there's terms that are understandable, like syndrome, you and I, in a certain context, use it differently than lawyers understand it. You and I say syndrome, we understand that it doesn't mean the requisite of each and every single component of that syndrome. But that's not the way lawyers understand syndrome. So if you don't have each and every single element of that syndrome can't be. So they don't even understand that. So where do we go? How do we fix this? So you and I could continue along the path of doing what we do best, okay? And I don't mean that we shouldn't. Not saying that we shouldn't advance the science, because that's our wheelhouse. That's exactly what we do. We probably should advance some of the science. We should continue finite element modeling. We should continue neurobiomarker research. We should continue epigenetic work in diagnosis. But that can't be where it ends for us. We have to be mindful of the translational aspect of this. You and I would give you that you've probably gotten an A grade for some of the science that I've given you. We've probably gotten an A grade in our bench to bedside work, but I would give us a D or an F in our bench to bench work, okay? We have not translated this information well for these colleagues that have to ingest it. We have not done that well at all. So if you and I were going to go, how do we translate it well? How do we fix this system? This is my final Venn diagram, and I apologize for the busyness of this slide, okay? It's simply to give you the proposition that this is complex stuff, especially if you and I are going to approach it from a macro systems perspective. If you and I were to try and fix all the different layers of this system, even starting with the medical expert at all, we would probably have to have significant professional oversight, much greater than exists today. We'd probably have to confine the medical information a little bit more narrowly than we typically enunciate it today in court. It would be beneficial if we, as a group, a large societal group, professional medical societal group, published consensus statements so the other rest of the world could kind of know what we were thinking, but that's kind of difficult on each and every single topic. And then attorneys would have to be able to ingest it. So they would have to have some sort of basic improvement in their science work, right? They would have to have some basic understanding of statistics. They would have to probably start even understanding the various roles much better of all the different subspecialists involved. You can kind of get the flavor of where I'm going at. This is complex stuff if you're talking about multi-systems change, which is probably why it hasn't happened well so far. Well, what can we do? What's low-hanging fruit? What can we do, you and I? Everyday solution. Let's start with what you and I can control. A simple thing. Watch your documentation. Watch your language. I still see it littered today. Perpetrator. Dad looks like a perpetrator to me in the medical record. Watch the language, okay? You can't use presumptive language in there, negligent, appropriate, things that can be confused in legal. And if you don't know what could be confused, you have wonderful child abuse colleagues who can help you with documentation, more appropriate documentation, or can give you guidance on, is this something that's sound, that's going to cause problems down the road? That's essentially what the specialty works at helping, is translating some of this communication into other courts, into other systems, sorry. But I'll tell you, basically, the concept is simple. We have to really integrate these two systems, these two professions much better. We have to work more routinely with child welfare, which we do a little bit better, but especially with the legal system. And we have to do it more fundamentally. Something like core roots of education, law students and medical students doing seminars together so they understand the way each other think and approach problems. Even include schools of social work in there. Multidisciplinary basic roots education changes. We can also make inroads into judicial education. I don't know if you know this, but judiciary are required to be educated annually. They have continuing judicial education conferences, and they are welcoming medical speakers. So before we impugn Dr. Kemp for getting us into this mess, okay? I want us to, I want us to understand that he actually had a vision and a great deal of wisdom far beyond his years. In 1978, Dr. Kemp hired a legal counsel to the child protection team. This is 1978. His name was Don Bross. He was my mentor when he was the last member of the original Kemp child protection team. He was my mentor when I went there at Children's Colorado. And Don Bross told me that when Henry Kemp pulled him aside, he said, look, I want you to join our team. And I want you to understand, I'm not going to pay you hardly anything. Okay. And I'm going to want you to do a lot of different work. And it's going to be really long hours, but your work's going to be important because you're going to bring two worlds together. And what did Kemp go out and what did Don Bross go out and do? Bross then went ahead and started multiple child maltreatment societies like the International Society for the Prevention of Child Abuse and Neglect, the National Association for the Counsel of Children. He actually held academic positions in both the schools of law and medicine, taught both classes on the various aspects of roots thinking for each side. Then he went out and actually made inroads into judicial communities, routinely lectured at judicial conferences, and local prosecutors associations, and even established catch grants in the Rocky Mountain region where cold cases were independently reviewed by multidisciplinary teams. That was the value of having a medical legal educator. He brought together in a routine way systems where they couldn't quite understand each other. Now, for obvious reasons, where you and I struggle in financial worlds of academic institutions, this hasn't taken a hold in a large degree of institutions. But I'm telling you, the concept is there. So let me go back to this one. This is my last thing. This brings me back to the Choluteca Bridge, okay? So the story of the Choluteca Bridge is this. This was a bridge that was contracted by the Honduran government in the 1920s to the Army Corps of Civil Engineers, because this river that the bridge traversed was a central river for trade throughout the country. And so in order to have robust national trade in Honduras, this river had to be bridged. And you here in this city of all can recognize the value of bridges. And so the Army Corps of Civil Engineers created this Choluteca Bridge in the 1920s. And for decades, it stood as the stalwart in Honduras until the 1990s, when Mother Nature struck. Some of you again may not know this, but a really, really significant hurricane ravaged Central America. Hurricane Mitch came through and ravaged the country of Honduras, left it in complete shambles, almost an entire mudslide. But guess what? The Choluteca Bridge stood. It did not falter one bit. The Army Corps of Civil Engineers won, or so they thought. Mother Nature had other ideas for the Choluteca Bridge, and so instead of utilizing that bridge, she moved the river around that bridge. And now it's known as the Bridge to Nowhere. And I submit to you, if we continue to approach multi-systems problems like abusive head trauma in just simple, siloed, one systems perspectives, I submit to you that we're going to stay on that Choluteca Bridge. This is my favorite conclusion. It's written from a law review article by one of the nicest appellate judges that I know. And I think it summarizes pretty much everything that I want to say. So I'm happy to take any questions you've got.